Good afternoon, ladies and gentlemen. We're back. We're going to do another video and we're going to talk about hypertension today. Just want to deal with some basic nuances of what you guys will see in your clinic and try to give you just a general framework of how we approach hypertension in the nephrology clinic. I'm Dr. James Hall. I'm a nephrologist, been practicing for about 20 years, and I'm trying to help you as a primary provider bridge the gap from medical knowledge to clinical application. I know you guys are super busy. You guys work very hard. I know you're passionate about what you do, but sometimes, when you have to see a lot of patients in a short amount of time, some things get missed, especially when it comes to some of their not so serious medical issues or some of the labs may get overlooked. I want to be able to help you guys quickly diagnose hypertension and treat it effectively. There are many causes of hypertension, and if you miss some of the labs or physical exam findings that may be pertinent to your uh, diagnosis and treatment, you may not have the patient on the right medication. So we're going to just dive right in. First thing is you want to take a really good history. I know you guys know this, but history can really tell you a lot about what's going on with the patient. For instance, if the patient's mother and father had high blood pressure at a young age, that tells you this patient probably has a genetic cause of hypertension. If the patient had hypertension that developed when she was pregnant, then she could have PIH, pregnancy induced hypertension, or gestational hypertension, which makes her more likely to have long term hypertension. If she had a major, I don't know, stressor or something that could have triggered her blood pressure, or during the history, you find out the patient may be taking certain drugs. Cocaine can cause hypertension. We see that a lot in younger population. So ask really good questions so that you can uh, dial in what's going on with on the history. So you got your history, then you do your physical. So on physical exam, some of the things that you should look for are, for instance, if the patient has a large PMI, uh, like a pretty pronounced point of maximum impulse, you want to feel and find out where the PMI is. A lot of times that just means that the patient has left ventricular hypertrophy, which could indicate they've had long-standing hypertension. And that tells you, this is not a new phenomenon. This patient probably had hypertension 5, 7, 18 years ago. And that's helpful to you in knowing, okay, I need to get an EKG to see what's the extent of this patient's hypertension. Check for an S3 gallop when you listen to the heart. If you got an S3 gallop or S4, it could indicate heart failure. There's an extra sound there that tells you this patient probably has had hypertension a long time, since hypertension is the number one cause of CHF, congestive heart failure. Wide pulse pressure, the normal pulse pressure between your systolic and your diastolic should be around 40. A lot of studies show that if it's greater than 60, the pulse pressure, the difference between the systolic and the diastolic pressure, if it's greater than 60, that's a wide pulse pressure. Well, what causes that? Sometimes if you have sclerotic arteries, it can cause it. Aging can cause it. Even hypertension can cause a wide pulse pressure if you had hypertension for a long time. Iron deficiency anemia, high output cardiac failure can cause a wide pulse pressure. Sometimes aortic regurgitation, AR, can cause it also. So these are some of the subtle things that you can listen to, look for, check for swelling in the legs, check for a bruit, which could indicate a possible coarctation of the aorta. The history and exam can almost help you fully diagnose your patients. And of course, vitals, you're going to look at the blood pressure, but you also need to look at the heart rate. If a patient's heart rate is in the 50s, and this is a young male or young female who's in really good shape and their blood pressure is up, that tells you there's something pathologically going on with this patient. Um, so keep that in mind. So labs, what kind of labs do we nephrologists look for in patients who come in with hypertension and may or may not have kidney disease? Just one quick tidbit before I tell you that. Check out our free webinar below because we do have a lot of cases that I like to kind of talk about. There's so much learning that can take place in our cases. There's one case on here on YouTube that's really good. It's an 18-year-old guy with hematuria, proteinuria, and acute kidney injury. Check it out. There's several different parts, but he has a really good case that you can learn from. So check us out if you can. So what labs do you order when a patient comes in with hypertension? First thing you always want to look at a BUN and creatinine. Creatinine is the main thing that I look at to tell if the patient has kidney disease. That creatinine is used to tell what your GFR or creatinine clearance is. That gives you an idea if this patient has kidney disease. If the GFR is normal, then obviously, that's not the cause of their blood pressure. If their GFR is low, CKD could be causing their hypertension problems, or hypertension, long-standing hypertension, could have caused their chronic kidney disease. So you got two things happening simultaneously. One could cause the other, or that one could cause that. Always keep that in mind when you see a patient with hypertension and kidney disease. The other thing that I look at is potassium. If your potassium is high, there's a reason. If the potassium is low and the patient has hypertension, you need to think of certain medical conditions that really pop up when a patient has this series or this set of lab abnormalities. So hypertension, hypokalemia, and maybe metabolic alkalosis. So you check the serum bicarb. So you check the creatinine, you check the potassium, check the bicarbonate levels, and the patient has a normal creatinine, low potassium, maybe a high bicarb and hypertension. So you got a patient with hypokalemic metabolic alkalosis. What goes along with that? What I normally think of is a primary hyperaldosteronism. That's a very common cause of hypertension and metabolic alkalosis with hypokalemia. I also think of renin activation of the renin angiotensin system, such as what you see in patients with maybe renal artery stenosis. Cushing syndrome, that's another cause of it. And Little syndrome, which is basically a genetic cause of hypertension and metabolic alkalosis. And sometimes Bartter and Gittelman syndrome can cause that, but they don't have hypertension. So you got a normal tensive patient with a low potassium on a high serum bicarbonate, hypokalemic metabolic alkalosis, and their blood pressure is normal. Think Bartter and Gittelman syndrome. So, these are some of the main things that we think of when we see hypertension with low potassium and metabolic alkalosis. So, hyperaldosteronism, renal artery stenosis, Cushing syndromes, Little syndrome are the four big ones that we see. And you can check labs to try to see which one of these may be causing your hypertension and your electrolyte abnormalities. That's why it's so important to check lab work. The other thing that we talked about in the video that talks about the medical case is albumin. When you check a comprehensive metabolic panel, you do get your creatinine, your potassium, your bicarb level, but you also get an albumin level. If your albumin level is low, ding ding ding, don't think malnutrition. Think protein wasting disease. Some type of nephropathy, nephrotic syndrome, some type of condition is damaging the patient's glomerular basement membrane and they're losing protein. They're losing albumin or they're losing other proteins in the urine, which is causing their albumin to be low. So that's why we always check albumin levels. So, how do we treat these people? I mean, we got a patient with hypertension. They may or may not have some electrolyte abnormalities. What do we do to treat it? So let's talk about it. The first thing you want to look at, if the patient has essential hypertension, which is basically run of the mill hypertension that Most people get from being a little overweight. I know none of your patients are overweight. That's just only my patients. Uh, or eating a little bit too much salt. I know none of your patients eat too much salt. That's only in my clinic. So, but if they do have essential hypertension, you want to look at an ACE inhibitor or angiotensin receptor blocker, and you can give a hydrochlorothiazide type agent. Those are really good first line agents for essential hypertension. If the patient has congestive heart failure with hypertension, you want to look at your beta blocker, like carvedilol. Those are really good for patients with CHF. They help reduce afterload and also help preserve cardiac output. If the patient has primary hyperaldosteronism, we always give those patients aldactone. Aldactone blocks those mineralocorticoid receptors in the kidney, and that prevents some of the potassium wasting, and it also lowers the blood pressure because you don't have that severe mineralocorticoid effect happening at the level of the kidneys. And so we're reversing that, and that lowers blood pressure. Sometimes it's completely curative with patients with primary hyperaldosteronism. Matter of fact, it's not quite as well diagnosed in our patient population. So that's why I always check for it. We check a renin and aldosterone level. But, you know, like I said earlier, when you see that low potassium and maybe some metabolic acidosis, metabolic alkalosis in the setting of blood pressure, that's your cue. Think maybe hyperaldosteronism. What else? We check for Little syndrome. If a patient has Little syndrome, we always treat that with a Miloride. That's a really good dose to block that sodium, epithelial sodium channel in the distal tubules, and that helps block some of that potassium wasting, and it also lowers blood pressure. Bartter syndrome, we talked about that earlier. Bartter and Gettleman syndrome don't usually cause hypertension, but they do cause hypokalemia and metabolic alkalosis. I think what I'm going to do is do another video with those two conditions just to kind of give you guys insight so that when you see these types of abnormalities in clinic in the electrolyte profile, you will know and you will think Barter's or Gettleman syndrome. And you won't have to go do a lot of research and studying. You already know what to look for. So one other thing, if the patient has proteinuria, when you got hypertensive patients, we talked about labs, you always get a urine. You get a UA to see if they has proteinuria. We get a urine protein to creatinine ratio to give us how much urine protein in 24 hours. So you can take a spot urine sample, take the urine protein, divide it by the urine creatinine, and that will give you how much protein in grams your patient is spilling in a 24-hour period. That's so valuable as a primary provider, as a nephrologist. That's gold information. If I get a patient in clinic and they have proteinuria and hypertension, I'm always going to put them on a renin-angiotensin agent, such as an ACE inhibitor or angiotensin receptor blocker. Those drugs have a very good anti-proteinuric effect, proteinuria lowering effect. So that's why we use them more so than any other drugs in our clinic. So I hope this video was helpful. Go back and review it. I'm gonna probably hit this again, just kind of as a review and probably from another angle, because the way that you learn in medicine is you have to read and you have to see patients. You have to have the medical knowledge, but you have to take all that and bring it to your clinic and put it into practice. And then you go back and read some more. And over time, you will start to build your repertoire of how to actually manage a really, really sick patient in clinic without even having to go just review because you've seen it enough and you've read about it. And as a nephrologist, that's what we want to do. We want to help you bridge the gap from medical knowledge to clinical application. Check out our webinar, check out our CKD course we've created online, and check out the next video. It's going to be good, I promise you. Thank you for listening. Send me questions and ask me things. And if it's something you want to talk about, let me know. I am all ears. Thank you. I appreciate it. And I will see you in the next video. Goodbye.